Welcome, everyone. My name's Rob Platika, and I'm a project manager with Admedicum. We're going to be using Wordly translation for the first time ever here. So, if possible, Wordly works best on a computer or a desktop, and it's harder to use it, but it still should work on a mobile device. You also need to join the meeting via the Zoom app and not via the web browser, which some might do. So I'm going to start the Wordly session now, and you should see the option that Bizana is inviting you to use a Zoom app. So you just want to click open there. So that pop-up should be appearing about now. If you know English and you don't need captions, you can just ignore it. Then the second option you just need to do inside the Zoom app is to translate to the language that you want the captions in. And then last, and I'll share this in the meeting chat, if you'd like to listen alongside the captions and have kind of the audio, you can click this link that I'll share in the chat and pick your language there too. So thanks. So we hope this will work well for some in our international community. And with that, I'll hand it over to today's moderator, Sandeep. Thank you.
Yep. Thanks, Robert, and thanks, Pisana, as always, to organize these webinars, which are very informative. Good afternoon and good evening to we all are from different parts of the world, so wherever you are, and welcome to this next edition of this webinar. And today we are going to touch into some different parts of the world. We'll have Professor Simon from Australia will be doing his first presentation and discussion about his experiences from Africa and Australia. And then we have Dr. Bobate, who will be talking about his experiences from India. And then now we have Ayotunde, who would be our patient representative from Africa. She will be sharing her story and as a patient with PH, the challenges or her experiences. And lastly, let me introduce myself. I'm Sandeep Sahai. I'm a pulmonologist and I'm director of the Pulmonary Hypertension program at Houston Methodist Hospital, Houston, Texas. That's where I practice, and primarily I'm a clinician and involved in many patient care of the PH patients and also in many clinical trials. So with that, I'll pass it on to Professor Simon to introduce himself and then proceed with his presentation. And subsequently, we'll have Ayotunde after his discussion to discuss her story, and then to Dr. Bobate. Thank you.
Thank you, Sandeep, and thank you for the warm welcome, and welcome to everyone from all over the world, hopefully listening and watching this webinar. It's my privilege to talk to you firstly about this important subject. Hopefully there's a translation for Australian. I'm originally from England, but I think I speak Australian now, so let's hope the translation works well. I wanted to start with a few slides, if I may, and Robert's going to help me. Just really giving you a background from pulmonary hypertension from a global perspective, if you like, all the way from Australia and then across to Africa. And this first slide is actually, I think, a very important slide. And this comes from the National Echo Database of Australia. The National Echo Database of Australia is quite unique in that it's the largest linked database of echocardiography to mortality. And these are data from more than 500,000 individuals. And if you see on this bar graph from the lowest point of what's called the estimated right ventricular systolic pressure, which is a sort of a mirror image of the pressures within the pulmonary circulation. And I am conscious that we've got a pulmonologist here, Sandeep, so you'll forgive me if I make any missteps here. But But really, what I've just got a meeting here that I can't see Professor Simon's screen. Is that an issue for anyone? Sandeep?
I'm able to see, but seems like Dr. Babade mentioned that he's not able to see the screen.
All right. So we might be held out as everyone else. Tunde, you'll be able to see my screen?
Yeah, I can see.
Okay,
Okay.
great.
Yeah, I can see now. I can
Oh,
see.
he's okay.
Beautiful. I'm good. So this is my first slide, and this is from the National Echo Database of Australia. And really what I want to show you is that the main lesson from this, so this was echocardiographic data. Obviously this is not a right heart catheterization, which is really hard to do, of course, in any setting other than a very high level tertiary care center. But the important thing from this seminal paper in the Journal of the American College of Cardiology shows in the bar graphs, in blue is actually your 1 year mortality, and then on top, 5-year mortality. Once you reach what's an estimated right ventricular systolic pressure, which is a low probability or mild pulmonary hypertension, there's a mortality signal. And you can see a stepwise increase from left to right as the pulmonary pressures go up. Now, the reason why I want to make this point really quite clear is that there tends to be a dichotomy in the clinical medicine, the management of patients who either reach a threshold of treatment or
Hello,
otherwise.
sorry, I can't hear. Oh, sorry.
My apologies, sorry. I'll keep going. And so the critical point here, if people are aware of the European Society of Cardiology recent guidelines on systemic pulmonary blood pressure, there is now a acknowledgement that there's a continuum of risk from a low pressure to higher pressure. And I think this is something we need to embrace when we're talking about the early detection and management of pulmonary hypertension, because the earlier we find it, and treat it, if we have treatment modalities, and perhaps Sandeep and the others can talk about this, the earlier you can treat pulmonary hypertension and keep the pressures low, the more lives you will save. So Robert, if you could give me the next slide. So if you actually think about pulmonary hypertension, there is very little epidemiological data. And why is that? Well, that's pretty simple, because if you want to definitively diagnose pulmonary hypertension, you maybe have a suspicion of what's happening, and you'll put someone into a cath lab. They will do a right heart catheterization, but that's pretty well impossible to do from a population level. So these data I want to show you, these are unpublished, but hopefully being published very soon, are just the extrapolation of the data we found from the National Echo Database of Australia to the whole population globally, based on the age and sex profile and pulmonary pressures. And I think you can see, if you just hit a couple of times there, Robert, for me, underlying Latin America and Caribbean, yes, and then again in Sub-Saharan Africa, Southern Asia, and one more time, you can see the distribution of pulmonary pressures. This is in men. We estimate there are more than 15 million men aged between 20 and 79 years living with elevated pulmonary pressures. And if you hit the next button, please. And then you look at women, you can see an equivalent number of women of 15.5 million women worldwide. If you look again in Latin America, that equates to just under a million individuals in Latin American Caribbean. If you can hit the button, I'm concentrating on the global south, if you like. In Sub-Saharan Africa, more than 1 million cases. If you look at Southern Asia, more than 3 million cases. And then you see in places like Australia and other countries in the global south, there's a substantial number of cases. Now, overall, if you look at the global burden of disease, there's an estimate that about 1% of the population have pulmonary hypertension. We don't think it's that high. We think it's more like 0.6% when you're talking about an active population from 18 to 79. But the next slide, if you can just hit the button for me, Robert, tells you the critical difference and between north and south. So this is now total cases estimated across the world who are aged 20 to 44 years. So this is the younger generation in whom you might expect more idiopathic pulmonary arterial hypertension. And so a younger, and this is in women, and with no left heart disease, and we'll get to the causes of pulmonary hypertension in a minute. You can see at North America, we estimate, and there should be a little dotted line coming up if you can hit for me, Robert, that about 4% of all pulmonary hypertension cases are made up of this particular group in women aged between 20 and 44 years. And if you hit the button again, compared to sub-Saharan Africa, when in actual fact, it's more like 12% of cases. So the burden of disease, of elevated pulmonary pressures, are very different between high-income countries, older populations, and places like sub-Saharan Africa. And why is that so? If you can hit the button again for me. Now, this is from the paper that we published in the Nature Reviews Disease Primers earlier this year, led by my good friend and colleague, Anna Mukumbi, on pulmonary hypertension. And you can see in this top bar the difference between the pathways to pulmonary hypertension. And this is the most prevalent forms of pulmonary hypertension overall for North America, South America, Europe, Middle East, Asia, Africa. Estimated the number one cause is probably left heart disease, closely followed by lung disease. And in many of the high-income countries, this is the predominant pathway to pulmonary hypertension. But as you can see in places like Asia and Africa, that there's actually a very strong component to rheumatic heart disease, sickle cell disease, and of course, HIV. And so when you're looking at pulmonary hypertension from a global perspective, it's very hard to say one pattern of disease in one country is going to be the same as the other. It's clearly not. And in actual fact, in some countries of the world, particularly in Africa, there's a predominance of young women who have developed pulmonary hypertension, and they're very different from the cases we have in the rest of the world. If you can just hit the button again for me, Robert, you'll see that when you're looking at pulmonary arterial hypertension, then you can see the different causes of systemitis, congenital heart disease, portal hypertension, HIV, connective tissue disease, and idiopathic pulmonary hypertension. Very vastly different pathways, natural histories from North America, South America, and Africa, and Australia. And even Australia, there's very much difference in the pathways to pulmonary hypertension. So what I think the key thing for us to take from this, yes, there's a common pathway to pulmonary pressures, a common sort of a symptom, if you like, and then a physiological pathway, but how you got there, what the triggers were, are very different between people living across the world, and particularly in the southern part of the globe. I think there's one more slide. There's just this one slide from an African perspective. So Anna and Mukumbi and I actually published this paper in Nature Reviews Cardiology. We've been thinking about how do you find pulmonary hypertension in an African setting. And I don't want to bore you with the details, but this is really just our way of looking at, if you presented to an emergency department in sub-Saharan Africa, how would you go about teasing out whether or not it's pulmonary hypertension as opposed to some other form of heart disease or pulmonary disease? And so we actually developed this pathway, and we're working on a program now trying to implement this to see if this can work. And it is a combination of clinical profiling using BNP, using ECG, and using portable spirometry. I think the game changer in this, in actual fact, could be the portable echo. The only problem about portable echo, though, is it tends to focus on getting left heart disease, and getting the right views of the right ventricle are a little bit trickier. So to actually teaching people like lay people or in an emergency department to actually operate an echo, a portable echo, to actually screen for pulmonary hypertension might be problematic. But we definitely need to move in that direction for changing the paradigm of how we find pulmonary hypertension in the African setting. And I do know there's just one more slide. Thank you. And so let's talk about vulnerability and climate change. And I've been fortunate. I'm spruiking, my apologies. This book of mine has just come out. I've actually got a hard copy here, if you bear with me. This one's just come out, my book on heart disease and climate change. And the reason why I've mentioned this is because it's very interesting, because pulmonary hypertension, in my mind, so cardiopulmonary disease is probably one of the things that will actually change. The pattern of pulmonary hypertension is likely to change as climate provocations to our health change. And in actual fact, this is what I did in part of the book, was looking at the different drivers of what will move in terms of infectious diseases. And it's interesting to see, for example, and people know, but things like Chagas disease has actually started to move with climate change into southern United States, while you've got some other infectious diseases which are pathways to pulmonary hypertension, will actually strengthen infectious diseases and strengthen the challenge to the lung and the heart. So if we don't actually develop pathways to the better detection of pulmonary hypertension in low resource settings, I think there's going to be a problem. And I think I'll stop there, but that's my big picture view of pulmonary hypertension. It's very different around the world. The experiences are different. And I think we have to have these forums to talk about shared pathways, knowledge about pulmonary hypertension, how we can help people. And I think drilling it down to an individual level for someone like Ayatunde, who's actually got that personal experience, is extremely important, because they're the people we're working towards to improve their health.
Well, excellent presentation, Simon. I mean, I think for me, practicing in the United States, sort of like an eye-opening in certain ways, and certain things which I never thought of are very important. I just have one question before we hand it over to Ayatunde. It seems like it's a pretty large database, or a lot of patient data, the echo data. I'm just curious about the methodology you used for this. Like, how did you, how did you collect all this data, or what methodology approach you used to come up with these numbers? I'm just curious to know.
No, it is a good question, and I hope the paper that I'm talking about with that data will come out soon. But the national database of Echo database of Australia is quite remarkable. It was actually set up by my PhD candidate of mine, who's now Professor Jeff Strange, and his partner, a cardiologist, David Playford. And essentially, what Jeff did for his PhD. He's an expert in pulmonary hypertension, and we did a nice paper in Armidale in Western Australia, where we showed that pulmonary hypertension was more prevalent than thought. But everyone said that can't be true. So what these guys did, an amazing thing, they went to all the people that produce the echo machines, so all the manufacturers, and they got them to reveal their codes for coding their echoes, which is really important. So one machine won't talk to another, but they got the code. And then they got agreement from, we now have over 45 hospitals Australia-wide, and we can scrape the direct echo reporting data from the machines. We put it together as a cogent database, and then we've linked it to the mortality in Australia. And next year, very exciting for us, we've now got data linkage on over 1 million patients with an echo, with more than 2 million echoes, linked to hospitalization, every medical procedure, and their prescribed treatment. So I'll be able to show you not only the mortality, but also the hospitalization. Now, very quickly, those global projections are based on the fact that we know how many Australians have an echo on an age and sex specific basis. So now we can map the results of NEDA. There's no clinical bias. It comes from who has an echo, what their results are, and then mapped out to the population and out to the world. And we're looking at a global initiative to actually address the weaknesses of the data I've shown you. But it's fascinating from that age and sex profile. It actually matches what we know is the actual epidemiology, if you like, of pulmonary hypertension in different parts of the world. So it's a good picture, but we need to do way more.
Fantastic. I mean, it sounds like a lot of work, and we really appreciate it. And as Pisana has sent a couple of comments for you, that of course the diversity of the etiology of pH is fascinating. That how it
Yes.
changes from each region of the world. And I guess our diagnostic and treatment approach should be more inclusive to consider all these options. And she also mentions about the climate change. I guess that is something that was briefly talked about in the World Symposium. And I guess now you have a book on that. So that will be really something we'll
And
be
and
looking
it's
for.
free online. So let me
Okay.
tell you, everyone, it's a online book and it's a free download. So you don't need to buy buy it. It's already paid for. And please read it. And love to have people's comments on that.
Perfect. Perfect. So I guess with that, let's move on to our second speaker, who is Ayatunde from Nigeria. And I will let Ayatunde introduce herself and share her story and perhaps highlight some of the patient perspective challenges or however way she wants to describe, or maybe some success stories or something in the areas, or identify those areas where we need to work more to help patients. Go ahead, Ayatunde, all yours.
Hello, good afternoon. My name is Hayatino Mitogun. Hope you can hear me really clearly. Okay, my name is Hayatino Mitogun. I'm from Lagos, Nigeria. I was diagnosed with pulmonary hypertension 11 years ago. So today I'll be discussing about the challenges assessing pulmonary hypertension care in Nigeria. So Nigeria, sorry, can I get the slide? Okay, so I'm discussing challenges assessing pulmonary hypertension care in Nigeria. So come to the introduction. Nigeria is the most populous country in Africa. We have a population exceeding 230 million in the world. But despite this vast population, we have very little awareness of pulmonary hypertension yet. It remains alarmingly low among healthcare providers and also the general public. And unfortunately, in Nigeria, we don't have a national data of the number of people living with pulmonary hypertension in Nigeria. So living in pulmonary hypertension in Nigeria, it is very, very difficult. It's highly challenging. Some of the challenges I'll be talking about are limited access to diagnostics, barriers to treatment. Sorry, can we get the second slide, the next slide, please? Barriers to treatment and lack of access to surgical interventions. In diagnosing pulmonary hypertension, the gold standard is the right heart catheterization procedure. And in Nigeria, unfortunately, this procedure is still not accessible. I live in Lagos, and in Lagos, we are the economic capital for Nigeria, and we have a population of over 20 million. And only one tertiary government hospital offers this service at a subsidized rate. Private hospitals and institutions provide these procedures, but it's really expensive. And a lot of people can't afford to get this procedure. And that is Lagos. Lagos is an urban area. And if you're talking about the rural area, there's a lot of rural disparities. People in rural area can't even get access, do not have access at all to this procedure. When I was diagnosed 11 years ago in 2013, I had to wait for 3 years, 2016, to get a final diagnosis and get a right heart catheterization done. So it took 3 years for me to get a final diagnosis, and also then I had to go to India to get another opinion. And you realize that in 10 years and 11 years since I was diagnosed, nothing has really changed. There isn't much improvement. It's still very hard getting this procedure done in Nigeria. Also, there's a high cost of diagnostic tests. Tests like the echocardiogram, the CT scans, the X-rays are still unaffordable to so many Nigerians. In Nigeria, less than 10% of the population has health insurance, so we have to pay out of pocket. I do also pay out of pocket for all my medications, my tests, everything. So it's really, really difficult and it's really expensive. And in Nigeria, a lot of people get delayed diagnosis. And there's a lot of lack of awareness among the health practitioners and also the public, leading to delayed diagnosis. And hypertension symptoms are very similar to other illnesses like asthma, tuberculosis. So yeah, they get misdiagnosed for that and mistaken for that. So the next barrier is barriers to treatment. There's very limited medications availability in Nigeria. In Nigeria, we hear about all the amazement advancement that's happening in the pulmonary hypertension community. And in Nigeria, unfortunately, we are left behind. In Nigeria, we only have oral medications, and the medications are like a bit accessible. We have Busetan, we have sildenafil, we have diuretics and blood thinners. And even this medication, like the Busetan, is not so easily accessible. I just started using Busetan last year. After diagnosis and I had to get a second opinion in India, I was prescribed an insulin receptor antagonist at Busetan, and it wasn't found anywhere in Nigeria. So I could only get it from India, and it took so many years for me to be able to. So many years that it took so many years for me to be able to actually get it to Nigeria. So if I couldn't get somebody coming from India to Nigeria, I won't get my drugs. During the COVID-19 period, I couldn't use medication because I couldn't get this medication into Nigeria. So I was actually very, very sick. Fortunately, Busetan is now available in Nigeria, but it's still quite expensive. And like I said, a lot of Nigerians don't pay out of pocket. They don't have health insurance to pay for the medications. Then access to oxygen therapy. We live in a urban city. Like I said, Lagos is the economic capital in Nigeria. So we have a bit of access to this therapy in the hospitals, and people who need to use out of hospital, who need to use oxygen outside, have to get an oxygen concentrator, which is expensive and not covered by insurance. And like I mentioned before, insurance challenges, because a lot of Nigerians do not have insurance. Insurance does not cover, like I said, doesn't cover medicine, doesn't cover diagnosis. A lot of patients cannot afford to get their drugs, and this also leads to treatment interruption. In Nigeria also, we have very limited expertise. Nigeria has no medical specialist. We have no pulmonary hypertension specialist in Nigeria for over 230 million people. So if, for example, like me, if I want to get treatment, I either go to a cardiac or pulmonology clinic. So there's no specific clinic for pulmonary hypertension in Nigeria. Then lack to access to surgical interventions. They don't have availability of surgery. So imagine in Nigeria, you need to get a PEA, or you need to get a lung transplant. You cannot get it in Nigeria. I remember there was a father who called me some years back, and he was really in distress. His son had pulmonary hypertension and end-stage heart failure, and the family was told to go to India to get this procedure because there's no way you can get it in Nigeria. And the family needed to raise about $1 million. When I heard it, I was shocked. Like, how do we start raising $1 million for this family? Unfortunately, the boy died, and because he couldn't raise the money, and there wasn't enough time to get this to get everything sorted. So in Nigeria, any patient who needs this surgery, this advanced surgery, so they have to travel abroad. They have to travel to like India or European countries, which is very expensive. Only a few Nigerians can actually afford to get to travel for these procedures. So the conclusion, I just brought out some ways I feel like we can actually help and Nigerian, or we can improve barriers to cares for people living with hypertension in Nigeria. I think we need to really increase awareness. Like I said, awareness is so low. A lot of people don't know about hypertension, even in the healthcare space. So awareness, we need to do a lot of awareness. Then also, we need to advocate for better health. Unfortunately, our health system in Nigeria is very poor, it's very, very bad. So we need to actually advocate to get a better healthcare system for people living with hypertension and other disease. And also establish dedicated PH clinics. We need PH specialists, people who are specialists who can give us better care and better treatment. Yeah, thank you very much.
Thank you, Tunde. That's, as I said, is an eye-opening presentation. I have a couple of questions, but before that, I think Lewis, in the comment section, has asked a question. Is health insurance not available, or is it too expensive in Nigeria? What's the issue with?
Okay, like I was saying, Nigeria is a poor country. I think 60% of population of Nigeria live in poverty, that's which is very sad. So it is quite expensive for some people, and even if it's affordable, like for me, for example, I cannot get health insurance because it doesn't cover a lot of the things I need. It can't cover my medications. It won't cover me getting the kind of treatment and care I need. So it doesn't cover a lot. So even if you get in insurance, maybe you're just going to get some care, like let's say for like malaria, for like typhoid, and so maybe some surgeries and all that, but it doesn't cover my own care, pulmonary hypertension care. It might not cover your oxygen, getting an oxygen concentrator. It might not cover you getting oxygen in a hospital if you need oxygen therapy in an hospital. So I hope that answers your question.
I think it does. I have one more follow-up question on that. So, I'm not very familiar with the Nigerian healthcare system, but is it more like a government-sponsored healthcare system, or it's more like I don't know, I'm taking the right example, but more like the United States, where everyone has to get or purchase or must have some sort of healthcare insurance. You know, what I'm trying to highlight is
Yeah, I understand. Yeah.
certain countries, the healthcare is sponsored by the government, but it's very subsidized. It may not have all the options or specialists and all, but there is basic sort of healthcare provided by the government system, and then there is a parallel private system, which is kind of like a healthcare scene in India, where you have government sponsored, which may not have your PH specialist, or maybe, but it's purely run by the government. And then there is a parallel private system also, where you self-pay and go and do what you want to do that way. So is it like that, or how is it there?
Okay, so in Nigeria, we have the government-sponsored insurance, then we have the private owned. And when it comes to hospitals, we have government hospitals, we have the tertiary hospitals, we have health centers. So the government hospitals are highly subsidized. So that's why I mentioned at first that it's in Lagos State with over 23 million population, really have one tertiary government hospital that offers the kind of catheterization and tests like at a subsidized rate. So we have the private hospitals, of course, it's better. Yeah, the disparity in the care gap is so much between the government and the private hospitals. But a lot of people can afford the private hospitals. Most people in Lagos, sorry, I don't have the particular number, access uses more of the government hospitals than the private. So only very few, like the 1% of the 1%, can afford to go to the private hospitals and get better care. But then unfortunately in private hospitals, even if you go to the private hospitals and you're paying a lot, you still don't get a PH specialist. You will still see either a cardiologist or a pulmonologist. But a pulmonary hypertension specialist, they are not in Nigeria, in the private or in the public sector. Is that the answers your question?
No, it does. It definitely, as Pisana is mentioning in the comments, that it's a very sobering, I would say humbling presentation, because we live in a different kind of world and the issues are totally different where we live. And then
Yes.
thing is not even a basic stuff is available to patients. Can I ask this question, that is there a patient advocacy or some grassroots level patient support system, like not the like healthcare you explained, but I mean like any patient advocacy organizations, like some pulmonary hypertension organization of Nigeria or African countries? Is there something like that, or people are talking about or making such an organizations, or have any updates on that or something to share about that?
Okay, so after I was diagnosed with primary hypertension, some years after, I decided to start a organization called Cardiac Community. And we try to raise awareness for cardiovascular disease. And one of our focus areas is pulmonary hypertension. Because I realized nobody was talking about this disease. It's not known at all. So we started advocacy and we started awareness. And we're trying to build a pulmonary hypertension community in Nigeria to bring people living with pulmonary hypertension together. So we have different initiatives. We have to raise awareness. Also, we started a new initiative to be able to get patients the pulmonary hypertension medications available in Nigeria. Like I said, in Nigeria, it's a poor country, unfortunately, and a lot of patients still can't afford to get this treatment. So yeah, so we are actually working on that. Our organization is working on that. So I try to build that, even though it's very challenging. We are very we're going through a lot doing that, but we're actually trying to do that.
Right. Well, we appreciate all your efforts for your health and also for helping others. I think you have vocalized concerns here, and many here. Of course, we are not in Africa or Nigeria, but at least we are connected to many people, organizations, societies, where we can suddenly bring these concerns up. And we hope
Yeah.
as you start to form your patient organization, so now we at least are aware of one point of contact who to reach out to help out further or even in advancing medications, resources, and or even the pharmaceutical companies can probably support some of the challenges which you are facing.
Yeah, but sorry, I just want to point on the pharmaceutical companies. Like we know pharmaceutical companies that deal with pulmonary hypertension medications globally. So unfortunately, in Nigeria, if you reach out to them, they tell you that's not a focus area. So maybe they might be focusing on things like maternal health. They might maybe a focus there maybe on cancer. So because pulmonary hypertension is now well known, and so pharmaceutical companies just want to focus on the issues that have more priority and maybe more support by the government or more focused area, like maybe communicable disease, like I said, like malaria, tuberculosis. So when it comes to non-communicable disease and like rare disease, specifically in Nigeria, that support is not there. Pharmaceutical companies are not even ready to involve themselves in those kind of, because maybe they feel we don't have the numbers yet. Yes, so they don't, even if you reach out to them and say, oh, the people living with pulmonary hypertension in Nigeria, how can we help them? We need to get drugs. They'll say, oh, pulmonary hypertension is in the focus area in Nigeria. They have other focus areas. So I think that's another challenge we face a lot. We're facing.
I think there is a question from Lewis. In your view, how can the other patient advocates from Europe particularly help? What do you think? Do you have any sort of any idea or any thoughts that other patient or advocacy organizations can help at the grassroots level in Nigeria or other sub-Saharan African countries?
So I wanted to confirm, is it the organizations in Nigeria or organizations outside Nigeria?
Yeah, basically organizations which are not in Africa. Do you think
Okay.
is there a process, or you think what kind of help they can provide to you?
I think is awareness. We need to really talk about the disparity in care. Like I said, we have the amazing advancements in medications and treatments, and in Nigeria we're left behind. So we need to talk about that disparity in care. Then people living in hypertension in Nigeria are like left behind. So I think maybe with better awareness, maybe it will help shine light on these challenges. Then also we can help with training. Like I said, we don't really have paid specialists in Nigeria. So if the paid specialists in other countries can help train we already the cardiologists, the pulmonologists, to get, you understand, to be more specialized and to care better for people living with pulmonary hypertension in Nigeria. That will also help.
Okay. Well, I guess it sounds like there may be an opportunity for other patient advocacy organizations or perhaps some other global PH organizations to maybe do some local meetings or symposium where they can
Okay.
probably spread more
Sorry, I
awareness.
can't hear you. I don't know if it's for me.
No, we can hear you. Can you hear us?
Yeah, I can hear you now. Um,
No, I was just saying that maybe there is an opportunity for other organizations, global PH organizations, to do more meetings and maybe some symposium there in Africa to spread more awareness among the healthcare providers as well as educate patients also about the
Yeah, I
symptoms.
think that would really be good, especially like with sickle cell. Like Nigeria is like we have the most people living with sickle cell in Nigeria, and unfortunately, there's still so little awareness, very very little awareness in the sickle cell community about the link between pulmonary hypertension and sickle cell. So I think yeah, that would really, especially if you can train hematologists or cardiologists, pulmonologists on the link between the risk people who are at high risk of getting pulmonary hypertension and also um so they can get diagnosed early, yeah, and get treated early, better outcomes.
Okay. Well, thank you for, such a sobering presentation and
Thank
opening
you
our
so much.
eyes to all your challenges. I think in the interest of time, let's move on to Dr. Bobate to discuss some of his experiences from India.
Hi. Yeah. Hi, Sandeep. Hi. Thanks for inviting me. So, sorry, I don't have a presentation. I was under the impression it's going to be question answer, but that's fine. So, yeah, I'm Dr. Prashant Bobate. I am basically a pediatric cardiologist, but I do look into adults also with pulmonary hypertension, and I'm based in Mumbai, India. And I was listening to both Professor Simon as well as Ayatunde, and I was thinking, wow, we are way in the middle of both the worlds, the Western world, where everything is available, versus the Saharan and Sub-Saharan countries where basic healthcare is also a challenge. And uh, yeah, so that's so when I first I came back after my training from Canada, and I wanted to set up a PH clinic in India. The first question was asked to me is, what are you going to do with PH? There are hardly any patients with pulmonary hypertension in the country. We have not seen too many PH patients, and there is hardly any therapeutic options which were available way back in that time. Maybe only ambrisentan, and to some extent, sildenafil was available. Uh, but we did set up a clinic here, try to get up all the specialities together, and try to seeing patients one by one and building brick by brick. So we are here now. Uh, in my clinic, I have approximately 800 Group 1 pulmonary artery hypertension patients with me. Uh, and as we say, India is actually, it's staying at maybe 2 centuries at one time. There are some patients who are both socially and economically, they are extremely powerful and very well to do, whereas there are others who are extremely poor, are not able to. So it was really a challenge to manage these disease and individualized therapy depending upon the patient's socioeconomic as well as educational status in the country. So what we started to do is was very interesting. Is I read a paper which was at that time a letter to editor in NEGM, wherein a pot shunt was done to connect the left pulmonary artery and the descending aorta. And that was helping patients coming off prostacyclin analogs. At that time, prostacyclin analogs were not available in the country at all. So we started doing this, what we call as a reverse pod shunt, and since we were a congenital heart disease unit, uh, it was not very difficult to convince my surgeons to try and do a pod shunt in patients who were having suprasystemic pulmonary arterial hypertension and who were already on medical therapy and was still worsening or didn't have the resources to take the medications which were as good as their 1 month salary. So we started doing this spot shunt and way back in 2014, and in last uh, 8 to 10 years, we have done approximately 36 or 37 of those spot shunts in these patients who have suprasystemic PA pressures. And what happens is because of the relieving of because the PA pressures become systemic, there is improvement in the heart function and there is improvement in the overall physical. So we're basically converting idiopathic PH to PH Eisenmenger syndrome, and the necessity of the medications as well as the patient's functional status improve. We did a lot in our initial years, but over a period of time, as a new medications started to getting available in the country, we had slowly we had macitentan, we had riociguat, we had celexipac, which is now available in the country. Although it is a little costly, our indications and our numbers of doing pot shunt have decreased slowly. We do also have prostacyclin analogs now, the especially the treprostinil, which is manufactured in the country, but for very strange reasons, it's not been marketed in our country. I don't know really don't know what the reason for that. But the but the country uh, but the company which is manufacturing it is actually giving it to some of our patients on compassionate ground, which has improved their functional class as well as improved the right heart function. And good thing is they don't have to pay for the medication, which may have cost them at least 3 or 4 thousand US dollars a month. So we have come up from where we were only a country which had only maybe one medication to two medications. Now we have quite a lot of medical armatorium in our with us. We also do have pod shunt. Lung transplant is still not readily available in the country, and it is really cost prohibitive to most of our patients. And the results also are we are not really sure at this point in time where we are from the lung transplant. But yes, we have progressed over the last 10 years. As Sandeep was pointing out, we also managed to, have a patient support group, which is called as a Pulmonary Hypertension India. It's a very vibrant patient support group. We established that in 2020, I think, and now there are already 5,000 patients who are part of that patient support group. And it's really amazing to see what a patient support group can do. I mean, none of our physicians would be able to do what they are able to do. They are providing day-to-day support to these patients who are having pulmonary hypertension, guiding them to proper specialists whom they may not be aware of, making medications available at cheaper rate. In fact, the treprostinil, which I am saying, the patient support group played an absolutely amazing role in convincing the pharma company to give it to our patients on free of cost. So they are amazing resource, and they are doing an amazing job. And I think Shalaka and her team are doing an amazing job, which is taking the care to another level. So yeah, I think that's about it. Sorry, it's a little extempore.
No, it was actually fantastic, and I think the story about, at least as much as what I have known from my personal experience early on, and then moving to the US and knowing about the changes over the years. I think you are right that the patient support group has played a pivotal role. And as many may not know, Prashant for the last 3, 4 years has been doing the National PH Symposium meeting where he invites international speakers and the national experts and specialists who have interest in pulmonary hypertension. Um, some of the things were fantastic. I actually attended for the first time with Prashant this past weekend. He invited me, and I can say that some things were really amazing, probably even we have not seen. They have pretty strong, one of the group, although it's in one part of the country, but very strong CTEF program for whether it's a PTE surgery, whether it's a BPA. I think they are doing fantastic job. Prashant's experience with pot shunt is definitely it's published also, and it's it's remarkable. Um, One observation which I learned after this symposium was um, the demographics of the physicians who are treating PH. And the reason I want to highlight that is because that changes a lot of things. And let me explain that. If you look at the US or the Western world, I'm not sure about the Europe, but at least in the US, and if you look at the PHA data, the 70% of the doctors who are managing PH or diagnosing PH are pulmonologists and 30% are cardiologists. And so when we are looking at that kind of physician demographic, you are probably uh, seeing um, a patient population. And if you look at most of the databases and the registries, you are identifying or the published literature from the US is top number is idiopathic, heritable PH, and then you have other groups also. As opposed to, this is just my observation, and Prashant could share that what I realized that the main PH doctors in India were the adult congenital heart disease, or you can say congenital heart disease cardiologist. So the screening of PH is primarily coming from the congenital heart disease patients. So I was just thinking later on that are we sufficiently screening PH in other populations? I mean, we are probably not seeing enough of idiopathic because I don't know where they end up with, who they end up with. But what I wanted to say is that for you, because you are congenital heart disease, so you have a direct access to a one form of pulmonary hypertension, which is what we are seeing predominantly. But I'm not entirely sure now, since you have established yourself with as a PH doctor. I'm sure anyone wherever they are noticing whatever type of PH, they are sending it to you. But I'm trying to sort of reverse the role. If you're looking just as a general pulmonologist sitting in the community, I'm not sure how much that pulmonologist or that cardiologist is aware of screening PH in a general patient population, dyspnea of an unexplained origin, or even in ILD patients, should they be looking for, or in COPD patient, they should be looking for. That's what I'm trying to highlight. And similarly, the other areas like portopulmonary hypertension, I'm not sure if the liver people are even aware of before the liver transplant. Should they be screening them for PH? I don't know. That kind of challenges probably they still exist. If you have some experience on that, if you could share.
Yeah, I think Sandeep, you are bang on. It is predominantly the so-called pediatric cardiac or congenital heart disease specialists who are looking after PH patients. Uh, the adult cardiologists are too busy doing their left heart disease
Yeah.
work. It's left with predominantly the right heart disease is predominantly sent to the pediatric cardiologist who are looking after the pulmonary hypertension. And being pediatric cardiologist, we also see a lot of babies and children with pulmonary hypertension with or without congenital heart disease. And that's how our, if you ask me, of my 800 patients, maybe around 30 to 35% of them are congenital heart disease and PH, which would be either before or after the surgery. I mean, the residual PH after surgery.
Yeah.
And now, because we are slowly established as a PH clinic, we have started to get more and more of the other types of pulmonary hypertension, especially connective tissue disease pulmonary hypertension, and idiopathic PH as well. And that's predominantly because of our experience with the pod shunt, our experience with using prostacyclin analogs. So that's how we are now getting the other types of PH patients also. But predominantly the referral is still with group 1. At least with me, it is predominantly group 1. The access to group 2 and group 3 PH, which is probably a larger portion of the pulmonary hypertension, they're still not coming to our clinic because of the specialty which we are dealing with. Now, the question is, how do we access and how do we make these people aware of when to screen and how to screen? So, as you said, that we are trying to do this kind of seminars, which apart from the biannual one which we had with you last weekend, we are also trying to do small seminars in different parts of the country, uh, maybe one each quarter into entire country. So, but the eastern part of the country is not much, as you may have realized yesterday. So we're trying to do it in small tier one and tier two cities on the western, northern, and the southern part of the country. And this small CMEs, maybe half a day CME on a Saturday evening or a Sunday evening, has helped us a lot to create awareness about the disease itself, about the treatment therapy, about the therapeutic options which are available. And it's also helped in convincing the pharma companies that, okay, we have those kind of numbers in the country where they would see some kind of where they will be able to uh, 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 I mean, I don't know. I'm trying to search for the right word, or maybe the medications would be used, which they are either manufacturing or trying to sell. So that's how it started. So, but still, if you see the most of the doctors who are treating pulmonary hypertension in India, they are still with the congenital heart disease doctors, but now more and more doctors are getting interested. Like when we started, we were probably the only one in the western part of the country. Now I already have one more adult cardiologist who is a transplant specialist in the same city who is also doing pulmonary hypertension. Similarly, there are other clinics which are set up in other parts of the country. Only last couple of months, I was in a small town called as Coimbatore in Tamil Nadu, where they had set up a PH clinic, and they were wanting to have a CME to educate the pulmonologists and the cardiologists and the treating physicians around. So yes, things are improving, and hopefully we'll go one step at a time, and hopefully we should be able to be there in the next 5 to 10 years, where would we have maybe 5 or 6 big PH centers and maybe many satellite centers who would be taking care of the primary things and referring when they are not able to refer, or they may be we may do something like a co-caring of the patients with the tier 2 and the tier 3 cities.
No, perfect. Now we
Yeah.
really commend all your effort and the patient support organization in India. I guess they have done remarkable work, as you have highlighted. And of course, your guidance to them and support has been remarkable. I feel like Ayatunde should probably get in touch with your patient if they are not already connected. Perhaps could share some, ways to set up the patient support organization in Nigeria, and perhaps to start there, and maybe they may need one or two motivated doctors to start the get the ball rolling.
Yeah,
Uh,
yeah. So as you would have known yesterday, just three patients who started. Out of those
that's
three, two were visiting me for their care. So that's how
oh,
it started. Now it has gone to 5,000 patients. So that's a big number. So
that's
I
great.
see a question by Pisana, who was asking about the non-invasive detection of pH. If you're okay, I can answer that
Yeah,
question.
yeah, sure, sure. I'm sorry, I didn't see the question, but yeah, go ahead, definitely.
Mm. So actually, the interest in the digital stethoscope to detect pulmonary hypertension early, it started when I was in Canada, and actually we had used a phonocardiogram at that point in time, and simultaneously we had recorded heart sounds and when the patient was doing a right heart cath, and we tried to see if the heart sounds would be able to by just by listening to the heart sounds would be we would be able to detect pulmonary hypertension. uh, we did good work for 2.5 3 years, and we published some 6 7 papers, but unfortunately we had the group dispersed to different parts of the country, and but that thought remained in my mind, and I was very interested when this IU Sync, which is an Indian startup, they came to me and said that we have this digital stethoscope and we need your help to see if we can be of any use to detect congenital heart disease or even pulmonary hypertension, and that's how we have started. So uh, we're still in the process of developing the algorithm. Uh, we're still in the process of, or maybe I would say we're still in the process of recruiting patients to recruiting patients. We already recruited 68 now, and our target is to recruit 200 pulmonary arterial group 1 pulmonary arterial hypertension, and then maybe we have some initial results with the 68 patients which we presented yesterday. And as you know, it's not a good sensitivity and specificity right now. Maybe specificity is 90%, sensitivity is around 85%. But we would want a screening tool which is more sensitive than specific. So hopefully, once we have the entire data set of 200 patients, we would be able to develop that algorithm. And once we have developed an algorithm, it would be very interesting to see if we can test it in the other centers of the country, as well as if we can collaborate with other centers worldwide, where we would be able to validate this algorithm. So keeping our fingers crossed. Thank you.
I think we had a great discussion, and we heard different stories and the challenges, and I think sounds like there is an opportunity for all of us to work together and collaborate on multiple levels, patients, physicians, researchers, industry. And I think what I'm seeing motivated people everywhere. So I think that's a very positive sign. So like Prashant started a few years ago in India, and now he's growing up, and I mean, he's already grown up to quite significantly in his area. Simon has done fantastic work. He shared with us. And I see Tunde is there, and she's motivated now. So I feel like the big changes start with one person. So I think we have those kind of people in all these regions, and I think that's a positive sign. So I think on that note, perhaps we are actually a little bit over an hour. So we can end, and I want to thank each one of you to share your work, your experience, and your stories. And I think this will be very helpful for us to guide our future and how we improve care for PH patients. Thank you, everyone.
Thank
If
you.
anyone has any other comments to share, please feel free to share.